I am recording. I'm pretty excited about this one for a myriad of reasons, but I'm even more excited to announce the following, and that is version 2.0 of the COVID-19 resource document's been posted on the MKRC Canvas site. Lots of new great addition, including the molecular biology of corona and COVID-19 virus in particular. Additional references have been added. Again, this is a living, breathing document that KCU comm students, including Yoo Min, student Dr. Yoo Min, have committed to updating from time to time. So this is the second version. Again, it's downloadable on the MKRC Canvas site. It's getting pretty big. It's somewhere between 50 and 60 megabytes, so I can't attach it as an email. But it's safe and sound and downloadable from the MKRC Canvas site. Super exciting. I can't say enough about the students who've produced this document. So let's turn it over to Ms. Shelley Boyer to give the formal introduction of today's speaker.
Thank you, Dr. Staudinger, and thank you everybody for coming. It is my pleasure to introduce SD Yoo Min Ahn. Before joining KCU's class of 2021, Yoo Min Ahn received her Bachelor of Science from Brandeis University in Waltham, Massachusetts, with emphasis in neuroscience, biology, and chemistry, before going on to receive her Master of Science in Forensic Science from University of California, Davis. She's been on the Honors and Scholarship Dean's list at KCU and is a member of the Psi Sigma Alpha Honor Society, as well as the winner of 2 scholarships, the KCU University Scholarship in 2017 and an abstract scholarship winner in 2016 from the American Thoracic Society. Yoo Min has authorship on the paper titled Age-Dependent Pulmonary Reactivity to House Dust Mite Allergen, a Model of Adult Onset Asthma, in the American Journal of Physiology, Lung, Cellular, and Molecular Physiology. Yoo Min takes extra interest in her topic today as she'd like to go into pathology following completion of her TO from KCU. During the shutdown, she's been an author on the COVID-19 resource document found on the MKRC Canvas site, which has been updated this week, as you all just learned. And if I could just please remind everyone to mute their mics and raise their hands. Dr. Staudinger or I will moderate the questions, and I will turn it over to you. Yoo Min, thank you.
Thank you so much, Shelley. I'm going to share my screen. And thank you everyone for coming. Can you see this pointer?
Yes.
Okay. So my topic is pathology and pathogenesis of COVID-19. Our first article was in the journal Histopathology titled Postmortem Examination of COVID-19 Patients Reveals Diffuse Alveolar Damage with Severe Capillary Congestion and Variegated Findings in the Lungs and Other Organs, Suggesting Vascular Dysfunction. These are the authors, and they're from 2 university hospitals in Switzerland. One is in Basel, the other is in Liestal. And this article was published online on May 4th, 2020. So to give some background, there are currently over 12.2 million confirmed COVID cases worldwide and over 554,000 deaths. This makes the case fatality rate around 4.5%. There's a lot of interest about COVID-19 pathophysiology, but relatively less studies are done about the pathology. The autopsies and pathology studies are needed to see the extent of organ involvement, not only in the lungs. Sorry, I'm going to ask the person living with me to lower their volume just a tad. Thank you.
No problem.
I can hear myself echoing in the background. So autopsies are needed to not only see the extent of disease in the lungs, but also outside of the lungs. And microscopic changes that are seen can help explain the pathophysiology of a novel disease like COVID. So from past coronavirus deaths, we know that they're mainly due to respiratory failure with acute respiratory distress syndrome, or ARDS. And in 2003 SARS, they also saw bronchopneumonias and organizing pneumonias, which basically is a sign of prolonged disease course. And the virus was also found in other organs. outside of the lungs. And in MERS in 2012, there's less data, but they found similar findings, but virus is more localized to the lungs, and organ damage outside of the lungs were mostly due to shock or other secondary causes. And in COVID-19, we suspect to see ARDS pathologically under the microscope. And there are different prognostic factors for different factors that signify poor prognosis in COVID, such as low lymphocytes in the blood, which is lymphopenia, and high D-dimers. And we don't understand why exactly yet. And study of pathology can help explain some of that. D-dimers are degradation products from formation and degradation of blood clots. So high D-dimers means that there's more coagulopathy, more clots being formed in the body. So how does SARS-CoV-2, the virus that causes COVID, infect humans? On the surface of the virus, there's a protein called the spike protein, or S protein. And this protein needs to be cleaved by a host protease in order to separate into S1 and S2. S1 subunit binds the ACE2 receptor of host cells, and the S2 receptor allows fusion of the virus to the cell membrane of the host. And then the virus can enter and replicate, and then vesicles of the virus can be expelled out of the cell and infect other cells. And in the human body, it's been found that TMPRSS2, a transmembrane serine protease, is one of the one of the proteases that can cleave this S protein, the spike protein. And cells that co-express ACE2 and TMPRSS2 were found in the nasal mucosa, the lungs, and ileum of the small intestine. So these might be sites where SARS-CoV-2 enters the human body. So after entering, how does illness present? What is the spectrum of illness in COVID? We know that about 80% or so of known cases are self-resolving viral illnesses, and then a smaller percent, about 15, can develop into severe disease with hypoxemia. Hypoxemia meaning arterial oxygen is less than 90%. And then about 5% can develop critical illness requiring mechanical ventilation or other interventions, and subsequently leading to death. Looking at hospitalized patients in more detail, this is a study from The Lancet in March. They looked at about 200 hospitalized patients in Wuhan, 54 of whom died. They compare the survivors on the top to the non-survivors on the bottom. And looking at them, they both present with fever and cough as their initial symptoms. And about a week later, they develop dyspnea or shortness or difficulty breathing. And the big difference that I see between these two groups is the involvement of different organ systems, multi-organ systems, as well as the fast deterioration to death. ARDS was also a big factor in whether they died or not. The non-survivors, 93% had ARDS, and only 7% had ARDS in the survivor group. So what is ARDS? In order to talk about ARDS, I'm just going to show what the airways look like in general. So this is the trachea. It branches down into the bronchus, into smaller bronchioles, and finally ends up at the alveoli. And this is what this is a silicone cast of a human adult lung. You can see the branchings, and they end up at this small alveoli that you can see over here. Sorry about the poor focus, but you can kind of tell that this corresponds to something like this here. And if you imagine this as like a cluster of grapes, the alveoli, we're going to zoom in on one single grape in that cluster and study the alveolus. So in this schematic, you can see the lining of the alveolus here, which is also referred to as the septum of the alveolus. The septum is lined by epithelial cells. And next to the alveolus is a capillary lined by endothelial cells. And usually in normal lungs, this would be filled with air. and there'd be very little space between the alveolus and the capillary so that you can get a good gas exchange. In ARDS, what you see is injury to the epithelium, and the dead cells, along with proteinaceous material called fibrin, combine to form hyaline membranes. And hyaline membranes thickens this distance between the alveolus and the capillary, making oxygen transfer a little bit harder. And also there's endothelial injury in the capillaries, leading to leakage of red blood cells, as well as immune cells like neutrophils, which add to the damage seen in the alveoli. Macrophages that live in the alveoli also become activated and secrete cytokines like IL-6, TNF-alpha, and IL-8. And altogether, this ARDS causes a pro-inflammatory and pro-coagulant state. There are many, many causes of ARDS, including shock, sepsis, infections, toxins, drugs, and radiation. So it's a very kind of non-specific disease seen in critical illness. Clinically, ARDS can be defined as having acute onset, that's within 1 week of a clinical insult or new or worsening symptoms. You need to see bilateral lung opacities on imaging, denoted by the white areas, patchy areas, which should be dark in normal lungs, and hypoxemia, measured as the ratio of oxygen in the blood to oxygen in the alveoli being less than 300 millimeters mercury. And this respiratory failure cannot be explained by heart failure or fluid overload. So now let's go back to the pathology. So what is the pathological diagnosis of ARDS? Well, it's seen as 3 big stages, but it's actually more in a continuum. The first stage is called early exudative or diffuse alveolar damage. And if you imagine kind of looking at a section of lung, taking a section and making a very thin slice of it, and then looking at it under the microscope, this is what you would see. On the left is a normal lung. You can see the septa of the alveoli here, capillaries. There's open spaces where the air is, and very little distance between the alveolar space and the capillaries. In diffuse alveolar damage on the right, you can see the arrows are pointing to hyaline membranes. The arrowheads show red blood cells denoting hemorrhage. There's a lot of cellularity, a lot of hyperplasia of those epithelial pneumocytes, as well as inflammatory cells. So you can see that gas exchange is very difficult, will be very difficult in this situation. And then the other 2 stages, I'm not going to go into detail in these because we don't see them as much in COVID, but the lungs become more fibrotic. There's more deposition of things like collagen, and you can even see some metaplasia of the epithelial cells later on. So going back to our article, what was the objective? The objective was to characterize changes not just in the respiratory tract, but outside, looking at other organs in COVID-19. They did a total of 21 autopsies of COVID patients, 17 full autopsies, which means they looked at the lungs, trachea, liver, heart, kidney, spleen, and when there were clinical indications, they also looked at lymph nodes, bone marrow, brain, and intestines. For the rest of the autopsies, they did partial autopsies, meaning they looked at the upper respiratory tract, lungs, and heart. They used a COVID-19 optimized protocol so that the staff would not get infected. And then they prepped and looked at the tissue under the microscope, also did immunohistochemistry, electron microscopy, and quantitative RT-PCR. Now let's look at the characteristics of the cohort. 81% were male. The average age was 76 years old. They all had comorbidities, and the most common was hypertension seen in all the patients, followed by cardiovascular disease, and then pre-obesity, obesity. Pre-obesity means BMI over 25. And then I thought it was interesting that 12 out of 17 had acute or acute on chronic renal failure upon presentation, and 14 out of 17 eventually developed renal failure during the disease course, so 14 total out of 17. And these are the initial lab findings upon admission. They don't share lab values for other times during clinical course. And the asterisk here denotes that this is only from the Basel group, which was 11 out of the 21 patients. This is the value that we're measuring. The parentheses means the normal range, and then on the right, this is the average followed by range within our cohort, within our 11 patients in the parentheses. So when we look at total white blood cell count, we see that the average is actually within the normal range, but the range in our group was very wide. And then you see low lymphocyte levels, so lymphopenia, which is a marker of poor prognosis, and elevated D dimers, as well as elevated IL-6, which are also markers of poor prognosis in COVID. And it was interesting to see that all 11 of 11 patients were anticoagulated at some point during their disease course. So now what did they find looking at the tissues? Overall, they found the lungs to be heavy, firm, congested, and unevenly bluish red. And the left shows a typical COVID lung. You can see thickened septa and interstitial congestion, which is shown by the white in this inset here. And on the right is actually a case of superimposed bronchopneumonia, which basically means a bacterial or some other source of pneumonia on top of their COVID pneumonia. And you can see the purulent material in the airways, as well as much more patchy redness, more disease-looking lungs. And they saw the superimposed bronchopneumonia in 10 out of 21 patients. And now, if you imagine again, taking a section of the lung and slicing a very thin slice off of it and looking at it under the scope, the left is what would be a normal lung again, and then the right is what they found. So all the lungs showed DAD, diffuse alveolar damage. And you can see the hyaline membranes in pink here, and they actually did an immunohistochemical stain for fibrin, which is a component of hyaline membranes. So you can see the vast involvement here. And then below, they show extensive capillary congestion. And it was interesting that the authors noted capillary congestion was worse in areas of the lung without extensive DAD. So that was interesting, but all lungs showed DAD and capillary congestion. And they also found syncytial cells, which are found in respiratory infections, as well as DAD. And below is a representation of microthrombi. So microthrombi are basically these small blood clots of fibrin, platelets, and RBCs, red blood cells, that can be found inside alveolar capillaries. And they found these in 5 out of 11 patients. And this is, again, the stain for fibrin, which shows the dark fibrin inside the capillaries. So to summarize the findings in the lungs, they found more often exudative than proliferative DAD. They found capillary congestion, microthrombi in 5 patients, superimposed bronchopneumonia in 10, pulmonary embolisms in 4, and alveolar hemorrhage in 3. So I'm going to move on now to the kidneys. So again, if you think about taking a part of the kidney and slicing it, looking at under the scope, this is what you'd see in a normal patient, a normal person, and this is the glomerulus, the unit of the kidney, in a normal patient. And you can see the proximal convoluted tubules and the distal convoluted tubules there. And up here is A and B is what was seen in our group. Left shows acute tubular injury. You can see there's epithelial cells that are being sloughed off right here and other places. So 14 out of 15 showed this, and those 14 were actually the ones that had renal failure in our group. And on the right, they show microthrombi within the glomerular capillaries. So in a normal glomerulus, the capillaries are pretty small with the red blood cells in there. But up here, in the you can see the microthrombi. Microthrombi are usually seen in disseminated intravascular coagulation, or DIC, which is usually attributable to shock. And they thought, the authors thought maybe the virus could have a role in the virus itself could have a role in injuries like this. So they looked under electron microscope and saw that viral-like particles were present inside vesicles of podocytes, endothelial cells, and the proximal tubular epithelial cells. So this is the feet processes of the podocyte, and this is the cytoplasm. You can see some mitochondria up here, and this is the vesicle, which is blown up on the right. You can see the viral-like particles within the vesicles, and they say that they measured the particles to be around 70 to 110 nanometers in size, which is kind of corresponds to the size of SARS-CoV-2. And again, you can see the vesicle here blown up on the right and right here. And in the heart, they mainly saw hypertrophy due to the hypertension that they saw in our cohort. And what was interesting was they found 6 cases of senile amyloidosis, and this was 4 times more prevalent than what they saw in age-matched autopsies in a normal year. So that was interesting, and they really didn't have an explanation for this, and the significance of this is unknown at this point. They also saw 3 cases of focal necrosis due to shock, and 1 case of acute myocardial infarction. This is a summary of findings in other organs. In the brain, they mainly saw hypoxic injury in 3 out of the 4 brains they studied. There was no inflammation or neuronal necrosis, and the viral RNA load was very low. In the liver, they saw 5 cases of shock necrosis. In the spleen, there was some acute inflammation in patients with bronchopneumonia. In the lymph nodes, they saw increased plasmablasts in 5 patients, and plasmablasts are immature plasma cells that secrete antibodies. And this is consistent with having an activated immune response. So in conclusion, they saw a lot of diffuse alveolar damage in all the patients, which can explain their respiratory failure. And they saw microthrombi in 5 out of 11 patients. And it is important to note that microthrombi can be a normal feature of DAD, but the fact that DAD was less prominent in people with microthrombi in this group could possibly explain that this abnormal coagulation may be contributing to their death somehow. So, and there was a lot of renal failure and acute tubular injury in our group, and viral particles were seen in the kidney, which means that the virus itself can contribute to this damage. And there was also a lot of secondary damage seen in multiple organ systems. Additionally, there was a disproportion of elderly, male, obese patients with severe cardiovascular morbidities, as well as being blood type A. 65% were blood type A. And this can be explained because, by the fact that A1G1 genotype shows the highest blood group antigen loading of 1 Willebrand factor, which means that they could have higher venous thrombosis risk. And this, like I said, the significance of the amyloidosis is unknown. So far, I haven't seen any other studies that talk about that. And some limitations are that the sample size is very small, and it's difficult to kind of difficult to attribute these factors to the virus versus ARDS, which is a very heterogeneous disease seen in a lot of critical ICU patients. And they also didn't do any side-by-side comparisons of their findings to other disease processes. So there are some future studies that can be done, especially with this amyloidosis too. Okay. And I'm just going to briefly talk about some other studies that were associated. There was a genome-wide association study in the New England Journal of Medicine that basically said 2 SNPs, or single nucleotide polymorphisms, were associated with COVID-19 patients that required supplemental oxygen or ventilation. And the location of one of these SNPs coincided with the ABO blood group locus. And when they did an analysis of the ABO SNPs, they found that blood group A was associated with a higher risk of requiring oxygen, and O is protective. And another study that looked at the proteomics and metabolomics of blood serum in severe COVID patients found that severe disease differentially expressed molecules that belong to three main pathways. These pathways were early immune response, specifically acute phase proteins and complement activation, and then macrophage function and platelet degranulation. And in other areas of the body, so there was a study that looked at skin rashes and found microthrombi in the rashes themselves. And when they looked at the lungs and the skin, they found a lot of complement activation. And a study looking at 18 brains showed that there was mostly hypoxic damage with little virus within the sections of the brains. And in terms of cardiac inflammation, it's mostly, they found mostly lymphocytic cardiac inflammation with little virus. And they actually didn't find any virus within the cells themselves, mostly just between the cardiomyocytes. And in the GI, there was also a case of lymphocytic inflammation around the blood vessels of the GI tract. And the right lower graph is just from a study that looked at 22 patients and the viral load in different organ systems. So we see that it's the highest in lungs, followed by pharynx, and the kidneys and liver were similar, followed by heart. And then there was basically none detected in brain and blood. Okay. So any questions or comments so far?
Dr. Schneider has a question.
All right. Yoo Min, thank you for a great presentation. I have a question for you just regarding to the first big publication which we discussed. So in the critically ill patients, if they do not respond to therapy, there is a sequence of events when first kidney goes off, after that liver goes off, and after that brain dies. And that is what if coming the worst scenario. And everything in this situation, like if we take these critically ill patients with the sepsis, is ending up with disseminated intravascular coagulation. When I heard and seen this presentation, it looks for me like that. Can you just speculate or discuss why there was a stopped short calling it disseminated intravascular coagulation?
I think the damage seen in COVID patients kind of creates a worst, kind of like like the endothelial damage feeds itself, I guess, because it's going to activate complement, activate more procoagulant states. I'm not sure if I'm addressing your question exactly. Can you repeat your question for me one more time? I'm sorry.
So, because we have multiple organs involved, and every pathology shows that there is a coagulation problems, which is which is a hallmark of disseminated intravascular coagulation syndrome. Why they are not calling it as a final stage of this disease? I mean, for infection with COVID-19.
I believe that they actually don't see the consumption of factors that would be seen in DIC. And I think someone else might be able to comment on this too a little bit better than me, but there are distinctions with DIC and this so-called COVID coagulopathy that they're calling it. But I'm not sure what the exact distinctions are. But I believe that you don't see consumption like you would in DIC.
Right, thank you.
No problem.
Dr. Johnston has a question, please.
Yoo Min, I want to compliment you on this presentation. This was at the level of a grand rounds type of presentation, or something that you would expect from a chief resident or maybe one of the attendings. So your level of competency and your depth of knowledge in this presentation is outstanding. So I want to compliment you on that. I too have some questions pertinent to some of the coagulopathy that's going on. You know, you had mentioned during the course of the illness that the patients were anticoagulated during the course of their illness. And with the concept of DIC, or a form thereof, they are bleeding and simultaneously clotting. And therein lies the dilemma of how to manage it. So did I understand you right by saying they were anticoagulated? Did you mean therapeutically and intentionally, or adversely as a consequence of the illness?
I'm actually not sure if they were all anticoagulated therapeutically, but definitely some of them were.
Okay. Did you see that they were placed on an anticoagulant?
Yes.
Okay. All right. So I got that. I understand it.
Mm-hmm.
The other component is that is an inordinate amount in quantity of amyloid from that small sample volume. To imply that what's the connection, all those folks got had some underlying culprit other than being obese and overweight, obese and hypertensive and 70 years old. They must have had some amyloid pathology before COVID ever hit them. It just sounds like 6 out of several, or not several, but 6 is a high number in proportion to the number of people that they did autopsies on.
Mm-hmm.
Is that unusual?
Yes, when they looked at age-matched autopsies that they did before, it was 4 times more prevalent in the COVID group. But it could also...
Yeah, go ahead, sorry.
But I think it could also just be by chance, because I haven't seen anything associated with amyloidosis yet.
Yeah, I'm saying you're not going to run into amyloid that frequently.
Mm-hmm.
I really did enjoy your presentation. I thought it was well done and very well explained. So you did a good job.
Thank you.
Thank you, Dr. Johnston, for your question, and Dr. Schneira. Dr. Johnston, did you have another question, or was your hand still just up from the first one? Oh, you're muted, Dr. Johnston. Dr. Johnston,
Yeah.
Can you hear me? Sorry.
I couldn't lower my hand in time.
Okay, all right. Thank you. Dr. Schneira, yes, go ahead. You have a question?
I just question for clarification. Mike, did you ask about amyloid P protein and where it was measured in the blood circulation? It's an acute phase protein if it is. So it's maybe generally reflect the level of immune response or inflammation in these terms, right? So because it is directly linked to high level of IL-6, usually the highest promoter or the strongest promoter of these acute phase proteins, including amyloid P protein. That was just as a comment. Thank you.
No, thank you, Alex. And if I might, Shelley, may I ask another question?
Please.
Okay. Yunan, in the management, and did you, and I trust that, and I did not read the article, so I'm naive there, so this is on me. But were high-dose steroids given in management of the ARDS situations. And the reason why I'm asking that, I'm going to say 35 years, 40 years ago, when we were trained on managing ARDS, we really learned the most as a consequence of Vietnam injuries and shock lung. That's where we learned shock lung. And the therapy at that time was obviously mechanical ventilation, but high-dose steroids. And lots of folks got into steroid psychosis and all the side effects of steroids. But was there much commentary relevant to usage? And if so, dosage?
I don't remember in the supplemental material if steroids were a part of treatment, and they don't discuss it in the body of the text, but I can check that and get back to you about that. To my knowledge, it doesn't discuss it.
Okay. Not that that was something that was quite popular several years ago. It has waxed and waned in usage, but I'm just curious.
Mm-hmm.
Yes, thank you, Dr. Johnston. I know that there was a talk on corticosteroids earlier in this journal club, and I am seeing that dexamethasone seems to be something that people are using. So just, I don't know, a side note of things that I'm still seeing on the topic. We have a couple other questions. Dr. Schneider has another question. Go ahead, please.
I would like to share with you my particular, because at the era when I was young, we of course considered the use of steroids based on the pharmacological doses of steroids causes stabilization of cell membranes. At that time, we did not know about cytokines at all. Later, it was discovered that it is one of the most important agents which can prevent cytokine storm, because it's knockouting NF-kappa B, and all of these cells, immune cells, and macrophages in particular, are suppressed by dexamethasone, which is now, as you know, British study shows that in critically ill patients, it is saved at about 30% of patients who went on ventilation. So here there was a change in the paradigm from being stabilizer of cell membranes when we use it for any type of shock, right? So now it's coming for this critical ill when it is actually prevents or inhibits cytokine storm. And most of these patients who are dying, actually dying because of the cytokine storm, term was introduced during Gulf War. All right, so that is my take on it.
Thank you, Dr. Schneider. We have another question. Dr. Wolf, please go ahead.
Everything, but among the things that was interesting to me is the activity of or activation of complement, and you may recall that I taught you the drug. Oh, I thought I put my camera on here. Sorry. The drug eculizumab is that complement C5 inhibitor that's used to treat paroxysmal. But my camera keeps turning off all the time. I guess I must. Sorry about that. But eculizumab is the complement component C5 inhibitor used to treat paroxysmal nocturnal hemoglobinuria. And I'm going, gosh, if complement is being activated here in these disease states, is eculizumab being used? And I did a quick Google search, and lo and behold, yes, it is. So it's of interest to me to see what impact complement inhibition will ultimately have on this, because I was dumbfounded actually the first time I saw how potent complement was when activated at killing things. And I'll end with that.
Thank you, Dr. Wolf. I actually had a couple of things, Yoo Min. One thing I was wondering, you mentioned multi-organ injury. Do you think that the multi-organ injury is due to this sort of effect that we were just discussing here, or that comorbidities are having a role in the multi-organ injury that you were seeing?
I think it's definitely a combination of both. Being older and more susceptible to multi-organ injury because of their comorbidities, and also the things that we're seeing like microthrombi and the endothelial damage contributing to that as well.
Okay, yeah, thank you. The other thing that I was wondering, when you showed the different tissue types that have the ability to bind, for this protein to bind and this virus to actually infect, was whether or not you thought, or other people could maybe have a thought on this, that certain tissues in some people may be more susceptible than other tissue types, which is why we saw maybe symptoms of diarrhea or stomach upset versus the respiratory cough in some people. Just some thoughts on that, maybe, please?
I do know that there's a study that says in the nasal epithelium, as ACE2 expression increases with age in a group of patients that they looked at. So that might have something to do with it. In terms of the GI tract, let's see. Not sure, yeah, why some would show mostly GI symptoms than others. But we have seen that GI symptoms are relatively less common in COVID patients. I think less than 30 to 40% have any GI symptoms, but yeah.
Yeah, I think you're right. I think that, I think that is one of the, something that they are seeing less. It makes me wonder, with your comment, if, we were hearing that you lose your sense of smell and taste that some people do, if that, if maybe those people have more of this ACE receptor in their nasal lining maybe than others that didn't experience that symptom. But I'll stop there. We have another question. Dr. Schneider, please go ahead.
Actually, it's not a question, but I invite everybody to express their opinion. I have a strong feeling, based on what information become available, that among other factors, it's also genetic predisposition is playing an important role. And we already discussed with Group A that it is 65% of these patients. Now, some publications are coming that there is a combination of 6 genes located in the chromosome number 3, which is a predisposed, and particularly talking about Bangladeshi, who is extremely susceptible to this and dying at high rate. Right, so that is what we should take that factor as well. It's not only pre-existing conditions, but also genetic predisposition to end up in severe form of COVID-19 infection. So if anybody has anything to comment on that, I will be pleased to hear your opinion. Thank you.
Yes, Dr. Schneider, I would comment to that. I do agree with you. I think that there is definitely some genetics that are playing a role here. And with genetics is usually coming predisposition thanks to our mom and dads. And so I think that with even the blood typing that Yoo Min showed with the SNPs and, was touched on there, that I think the more and more we study this, we're going to see that there are going to be some hereditary markers or genetic markers that are going to be more distinct for severity and risk of people.
And in that same study, actually the other SNP was that was in the same location of those 6 genes that you were talking about. And I think some of them are related to the ACE2 receptor and some are related to the immune response. So I think genetics is very relevant too.
Thank you, Yoo Min, and thank you for that first presentation. We'll let you go ahead and get started on the second one.
So the second article is titled Pulmonary Vascular Endothelialitis, Thrombosis and Angiogenesis in COVID-19. This was published in the New England Journal of Medicine online on May 21st. These are the authors, and they're mostly from university hospitals in Germany, Switzerland, and Massachusetts. So in this study, they wanted to learn the morphologic and molecular changes in peripheral lungs of patients who died from COVID-19. The methods they used were the optimized protocol to prevent spread. Then they looked at tissues after prepping them and under the light microscope. They also did immunohistochemistry, micro-CT imaging, scanning electron microscopy, corrosion casting, which is basically looking at the microvasculature of the lung, and then a direct multiplex measurement of gene expression. So they compared 3 different groups, lungs from 3 different groups. There was the COVID-19 group with 7 lungs, the influenza A group, also 7 lungs, and they were archived tissue from the 2009 H1N1 influenza pandemic. And they were chosen because they were the best possible match for age, sex, and disease severity to the COVID group. And in the age-matched uninfected controls, I think they mostly died from trauma or stroke, whereas the influenza group died from ARDS, respiratory failure, secondary to influenza. So what they found was similarly DAD, but they also found a lot of perivascular lymphocytes. You can see the hypercellularity around the capillaries here. And they found this in both COVID and influenza groups. And then when they looked at the lung weights, COVID-19 lungs weighed significantly less than influenza lungs, and uninfected controls weighed significantly less than the other 2 groups. And they attributed some of the higher weight in influenza A to excess fibrin and edema that they saw in histology. And in both COVID and influenza groups, they saw ACE2 positive cells in the epithelium, endothelium, and lymphocytes surrounding the vasculature. And when looking at those lymphocytes, they found similar levels of CD3 positive cells in both groups, but COVID-19 showed more CD4 cells, and influenza lungs showed more CD8 positive cells. And influenza A lungs showed more neutrophils than COVID lungs, adjacent to the alveolar epithelial lining, alveolar epithelium. So in order to study a little bit more about inflammation, they looked at 249 genes associated with inflammation and found that 79 were differentially expressed only in the COVID group, whereas only 2 genes were differentially expressed in the influenza group, and then 7 genes shared expression patterns in both groups. Oops. This study also found a lot of microthrombi, denoted by those arrowheads there, in both groups, influenza and COVID-19, but it was 5 times more prevalent in the COVID group. And then they looked at the thrombi a little bit closer. The top left shows an electron micrograph of the clot in pink, the asterisks. Then you can actually see the yellow lymphocytes here surrounding the vessels. This is another histologic slide of the thrombi, and then C and D are micro-CT based 3D reconstructions of the pulmonary arteries and airways. You can see that there's almost a near total occlusion of the arteries in COVID lungs compared to the normal looking lungs on the right. And when they further looked at the capillaries, they found a lot of angiogenesis. So they found 2 types, intussusceptive and sprouting. And angiogenesis means the sprouting or the creation of new vessels from existing vessels. And there are 2 main types. Sprouting angiogenesis, actually, I'll explain what this is. This is a schematic of normal capillary bed AV means afferent, afferent vessel and efferent vessel. And in sprouting angiogenesis, what happens is these stalks form, and they migrate towards the direction, and the stalks are made up of endothelial cells, and migrate towards areas of hypoxia or areas where growth factors like VEGF-A, I think, are being released. And then these stalks eventually join together to form a new vessel. And in intussusceptive angiogenesis in the middle, what happens is the two new vessels split from an existing vessel. And this happens by creation of this pillar, an intussusceptive pillar shown in P. So it's basically split off from one vessel. And what they found in our study was that both COVID and influenza lungs showed these two types of angiogenesis, but intussusceptive angiogenesis was 2.7 times more common in COVID lungs than in influenza lungs. And A is showing an electron microscopy of this corrosion casting of the capillaries. This is normal. And B is the intussusceptive angiogenesis, that they saw in COVID lungs. And C shows, in arrowheads, show the pillars that I just talked about in the previous slide. And when they looked at endothelial cells, they found viral-like particles inside them. So they think that the virus itself could contribute to this, this kind of distortion and angiogenesis seen here. So they call this severe endothelial injury. They could see disruption of the intercellular junction, cell swelling, loss of contact with the basal membrane, and the viral-like particles that I mentioned. And then they quantified the angiogenesis also. I mentioned that intussusceptive was 2.7 times more common in the COVID group. What they did was they also plotted the amount of angiogenesis as a function of the length of hospitalization. And they found that only in COVID lungs, the amount of both types of angiogenesis was directly correlated to the length of stay. Then they looked at 323 genes that are associated with angiogenesis and found that 69 of these genes are differentially expressed only in the COVID group, 26 are differentially expressed only in the influenza group, and 45 genes shared changes in expression in both groups. So in conclusion, both the COVID and influenza lungs showed diffuse alveolar damage with the perivascular T cells. In COVID-19, there was much more microthrombi in the pulmonary vasculature, endothelial injury, as well as the angiogenesis, and this angiogenesis increased with the length of stay. Again, the sample is very small in this study, and what's important to note is that 5 out of 7 of the influenza patients were mechanically ventilated, whereas only 2 out of the 7 of the COVID group were not mechanically ventilated, but just non-invasively ventilated. So this says that they might not have been at similar points in their disease courses. I think that's the end. Any questions or comments?
Thank you, Yoo Min. That was another great presentation. I know that we do have about 6 minutes left, so that is some time for discussion. If people do need to leave it too and we run over, that's fine. We'll just keep going. Let's see, Dr. Schneira has a question. Go ahead, please.
Yoo Min, again, thank you for a great presentation. And I am asking a question with the greatest respect of you. I'm asking as you, my colleague. So, in these settings, what you've shown in this publication in comparison with influenza. So clearly there is a CD8 cells. And after that for COVID, it is CD4. And after that, I'd like to bring that consequences of this when they measure angiogenesis there. So that is immediately turns me towards that the major response is here, at least terminal, is mediated by Th2 type of response, which is kind of leading to angiogenesis. they say only CD4 cells, right? So response. But did you see in another publication that will be specified whether it is CD4 Th1 cells or Th2 cells? If you don't have answer, I can understand.
I'm not sure about the the Th type of those cells. I'm sorry.
All right, but it will be interesting too. All right, so I'll look after.
Thank you, Dr. Schneider. Is there any other questions or comments for Yoo Min on the topic?
I think in terms of the topic is concerned, I know your background is strong in forensic science and in that discipline. And I just, again, can't say enough of how impressed I am of your depth of knowledge and how comfortable you seem to be in discussing this pathology. So again, that's to be complimented on your accomplishments at this level.
Thank you. I'm actually really nervous right now, so I'm not sure if that shows, but thank you so much.
It's called normal.
Thank you, Dr. Johnston. Those words, I'm sure, were very encouraging for Yoo Min, because I know she did work hard on this, and we appreciate and we see that work and effort. Thank you again, Yoo Min, for the presentation, and thank you, everybody, for coming and for participating. We do have another talk next week. I will send out announcements with the correct times and dates. My apologies on any confusion for the announcements this week. We will have another student doctor, third year, that has contributed on the COVID-19 resource document. Antu will be presenting, and again, we have our seminars on Thursday and another journal club on Friday. If everybody could please unmute their mics and show themselves, and let's give Yoo Min a nice round of applause for her presentation. Thank you, Yoo Min. Yes, I'll hand it over to Dr. Staudinger, and you guys have a nice weekend. Dr. Staudinger?
I don't have anything to say except thank you, Yoo Min. Your hard work was evident. Appreciate you.
Thank you.
Thank you. Everybody have a good weekend.
Bye now.
Bye.